Hi, Living Beyond Breast Cancer. I am Dr. Stephanie Graff. I am a breast medical oncologist at Sarah Cannon Cancer Institute, and I have been asked to talk about hormone receptor positive metastatic breast cancer. And that's a really big topic for 25 minutes. I'm going to try to hit some high points, and then hopefully on the live session after this, we'll be able to answer your questions. So first, just to sort of level set, hormone receptor positive means that the breast cancer is positive either for estrogen receptor or progesterone receptor or both. Most experts consider more low-level estrogen or progesterone receptor expression less than 10% or so to be an estrogen or progesterone receptor negative breast cancer. But most clinical trials, in order to enroll on a triple negative breast cancer trial, still require it to be estrogen 0%, progesterone receptor 0%. Co-positive disease then is cancer that is either positive for either of the two hormone receptors, estrogen receptor and progesterone receptor, and also positive for HER2. Typically in co-positive disease and HER2 amplified disease, we still treat according to the HER2 paradigm. So that's not going to be included in the body of today's discussion. I also am going to largely focus on the treatment of postmenopausal breast cancer. Breast cancer a person is defined as being postmenopausal if there has been surgical removal of the ovaries or if there's been absence of menses for a year outside of the ovarian suppressive effects of chemotherapy and tamoxifen. So typically in the metastatic setting, I recommend surgical oophorectomy, but there's some nuance there. If you are a premenopausal woman, for many of the treatments we're going to talk about today, it would require Zoladex or a similar product for ovarian suppression. Anytime somebody has a new diagnosis of breast cancer, it is always critically important that we start with a biopsy to confirm the diagnosis, and that we recheck the estrogen receptor, progesterone receptor, and HER2 status on the metastatic site. And that then we repeat those biopsies at intervals over the disease course so that we can make sure that the biomarkers are not changing. We know that about 15% of metastatic breast cancer is discordant compared to the breast cancer that was diagnosed in the earlier curative intent, stage 1, 2, 3 setting. And we know that sometimes estrogen, progesterone receptor positivity will change over the course of a metastatic disease treatment plan. The frontline therapy for HER2 hormone receptor positive metastatic breast cancer at this time is really CDK4/6 inhibitors. There are 3 CDK4/6 inhibitors, palbociclib, ribociclib, and abemaciclib. The trials looking at those, including the Mona Lisa study, the Monarch study, and the Paloma studies, have all shown excellent hazard ratios and response, showing significant reduction in progression-free survival. For both abemaciclib and ribociclib, we have robust data showing that they improve overall survival as well. These drugs have been studied in combination with the aromatase inhibitors and in combination with Faslodex. We typically consider using them in combination with Faslodex for patients who progress to a metastatic diagnosis while taking an aromatase inhibitor. For patients who have had a long treatment interval between when they stopped their aromatase inhibitor and when they presented with a metastatic recurrence, they can be used in combination with the aromatase inhibitors. There is some nuance around situations where we might do aromatase inhibitor, CDK4/6 inhibitor, even in somebody who has previously been treated with the aromatase inhibitor recently, but that's more of an individualized discussion. We also have some evidence looking at those meds in premenopausal women, perhaps most importantly, in combination with tamoxifen for ribociclib, and in combination with fulvestrant for both palbociclib and abemaciclib. And so we know that the combination there is safe and equally efficacious in premenopausal women. The three drugs do have slightly differing side effect profiles. We typically anticipate that palbociclib has the deepest degree of neutropenia. Ribociclib has a unique side effect that it can change the rhythm of the heart and cause what we call QT prolongation. So patients on ribociclib need EKG monitoring at intervals while they're on the medicine. Abemaciclib has a little bit higher rate of diarrhea and elevated liver function studies, which is unique to abemaciclib. All three drugs received a black box warning in the last year from the FDA for interstitial pneumonitis, which means just an inflammation of the lungs. That can be very serious. It's rare, but it's worth being aware of and monitoring for. When we look across all the CDK4/6 inhibitors to try to answer the question, is there anyone who doesn't benefit from these drugs? The answer really appears to be no. Dr. Jennifer Gao did a pooled analysis that was presented at ASCO in 2018 that showed that patients who are progesterone receptor negative, patients with lobular histology, patients with bone-only metastasis, patients with de novo metastatic disease, which means they present at a metastatic diagnosis rather than present at an early stage and recur later. And then patients who had had a long disease-free interval, so who had been off treatment and doing well at the time of their metastatic recurrence. Every single one of those groups got a benefit from CDK4/6 inhibitors that was very similar to the general population. So the takeaway is that probably everybody benefits from CDK4/6 inhibitors. Dr. Finn's group has also done some studies looking at molecular subtypes, and they compared luminal A versus luminal B breast cancers. Luminal A are classically the very hormonally sensitive breast cancers. So like an estrogen receptor, 100%, progesterone receptor, 100%, low grade, low proliferative rate or Ki67. Luminal B breast cancers tend to be the slightly more aggressive appearing population of estrogen receptor positive breast cancers, where the estrogen receptor is maybe 70% and the progesterone receptor is 20 or 30%. The proliferative rate would be higher. It's sometimes a grade 2 or grade 3 tumor. Luminal B and luminal A in those studies both benefited from CDK4/6 inhibitors. So at this point, clear standard of care for frontline hormone receptor positive metastatic breast cancer is CDK4/6 inhibitor, either in combination with an aromatase inhibitor or fulvestrant, depending on prior hormonal therapy exposure. So beyond CDK4/6 inhibitors, we have a bunch of different molecularly targeted drugs that are either approved or emerging. Approved include medicines looking at inhibiting Mtor as well as PI3 kinase. We do have medicines that are associated with a response in ESR1 mutations, and then some newer drugs that are maybe specifically selecting for them. And then also AKT inhibitors are an emerging treatment paradigm. So we'll talk about those things. First, for Mtor, there was a study done in 2014 that called the Bolero-2 study, that looked at women who had previously progressed on an aromatase inhibitor, and they were randomized either to exemestane, which is sort of a second generation aromatase inhibitor. It has a slightly different chemical structure than either anastrozole or letrozole, and randomized those patients to exemestane alone versus exemestane in combination with everolimus at 10 milligrams a day. And we saw that patients receiving everolimus in that study had an improved progression-free survival that increased from 3 months to 7 months. There was no statistically significant increase in overall survival. It was numerically about a 4-month benefit, but it was not statistically significant. I think that everolimus and exemestane still has a role, especially for patients that are trying to avoid systemic IV chemotherapy, and for patients that continue to demonstrate a high level of hormone sensitivity or a prolonged response to other hormonally driven treatment. regimens, but there is no, at this time, there's no evidence around everolimus after a CDK4/6 inhibitor. There is a study that looked at everolimus as a triplet in combination with a CDK4/6 inhibitor, and we're still waiting on those results. We also have evidence looking at PI3 kinase mutations. A PI3 kinase mutation can be detected on any number of genomic profiles. Your physician can order it through tests like Caris or Guardant or Foundation. There's also some pathology groups can test independently. And for patients who have a PI3 kinase mutant hormone receptor positive breast cancer, there is a study called the SOLAR-1 study that compared alpelisib in combination with fulvestrant versus fulvestrant alone. And we saw that that it met its primary endpoint of an improvement in progression-free survival. Patients who received alpelisib had a median progression-free survival of 11 months compared to those who received fulvestrant alone, who had a median progression-free survival of 5.7 months. This trial did include patients who had previously been treated with CDK4/6 inhibitors, and we saw that the response was the same regardless of whether or not they had previously had CDK4/6 inhibitors. They also looked to see if there was any difference between visceral versus non-visceral metastasis response, and the response was the same regardless. And so that represented a 35% reduction in the risk of progression or death, which was clinically meaningful. Alpelisib does have side effects, as does everything we do in the world of oncology. Most notably, it can cause hyperglycemia or high blood sugars. That can be very serious, even requiring hospitalization. It also can cause a skin rash, which can be is a grade 3 skin rash, which is a pretty serious skin rash in 22% of patients. And it caused diarrhea in about 50% of patients. So definitely some very real toxicities with alpelisib, but a reasonable treatment option if you have a PI3 kinase mutation. Moving into non-approved therapies, there is an emerging compound called GDC0077. It's always great when they don't have names yet, right? And GDC0077 is a new drug that targets PI3 kinase, and they are looking at it in combination with palbociclib and fulvestrant in frontline metastatic breast cancer, so previously untreated breast cancer, and that is an ongoing accruing trial. And the idea is that GDC 0077 is an alpha-specific PI3 kinase inhibitor, so we're optimistic about the combination of PI3 kinase drugs with CDK4/6 inhibitors, and also anticipating a slightly different side effect profile. So that trial is ongoing. If you have anyone with a new diagnosis of metastatic hormone receptor positive breast cancer, I would encourage them to consider and look for that trial. Next, there's also an emerging drug called capivasertib, which we're going to call Kappa for the rest, so that I don't have to suffer through that pronunciation. Kappa is an AKT inhibitor. AKT is a part of the PI3 kinase pathway, and so we see very high rates of AKT mutations in patients with breast cancer, hormone receptor positive breast cancer, and there is an ongoing clinical trial that's comparing fulvestrant, again, as compared to fulvestrant in combination with Kappa. It is a phase 3 study that follows up on the results of the phase 2 study, which has already been released. The phase 2 study was called the FACTION trial, and it met its primary endpoint of a 5.5-month improvement in progression-free survival for patients receiving the AKT inhibitor, improving from 4.8 months on fulvestrant alone to 10.3 months on Capi in combination with fulvestrant. So another good emerging option. Another clinical trial that's ongoing right now is using AZD9833, which is a SERD, which is a selective estrogen receptor degradator. Fulvestrant is a SERD. That's how fulvestrant works to block estrogen expression, is it sort of deregulates the binding of estrogen. And AZD9833 is an oral compound where fulvestrant is an injection. And so the idea is again that it's a little bit more of a patient-centered compound because it is an oral therapy. And so that trial is accruing. The name of the trial is the SERENA-2 study. There's a third emerging compound is called lasofoxifene. Lasofoxifene is a drug that was originally studied for osteoporosis. In the large osteoporosis study that was done using lasofoxifene, they saw an 83% reduction in the risk of developing breast cancer while taking it. So it seems to be an effective breast cancer risk-reducing drug. And because it was being studied in an osteoporosis trial, it also appears to have a positive net effect on bone health, which is obviously something that persons living with metastatic breast cancer have a lot of symptoms and side effects related to bone loss from the hormonal suppression that is a part of the treatment. Lasofoxifene is a SERM, a selective estrogen receptor modulator. So again, just works by blocking estrogen in a slightly different way than all of the other compounds. And there's also some evidence that it is an effective treatment for vulvovaginal atrophy or vaginal dryness. And so given the secondary benefits, bone health, vaginal health, it's an interesting drug to look at in the metastatic breast cancer setting. And the clinical trial that's going on with it is called the Alene Trial. And it is randomizing patients after prior treatment with a CDK4/6 inhibitor to either lasofoxifene, which is oral, or fulvestrant. So again, another interesting option for patients after progression on a CDK4/6 inhibitor. Beyond all of the hormonal manipulation that we use in hormone receptor positive metastatic breast cancer, there are numerous traditional chemotherapies that have been studied. Ones that are commonly prescribed continue to be anthracyclines, adriamycin cytoxin, paclitaxel. Those two regimens, adriamycin cytoxin and then paclitaxel or any taxane, remain the backbone of chemotherapy for breast cancer and are utilized in most patients' treatment course at some point. But we also have we also use capecitabine and eribulin pretty regularly in the hormone receptor positive metastatic breast cancer. But unfortunately, there remains lower response rates for patients who have hormone receptor positive metastatic breast cancer to traditional chemotherapy. In capecitabine, for example, in hormone receptor positive, the progression-free survival benefit was about 5.3 months. With eribulin, it was about 4 months. And those are just shorter endpoints than we want for our patients, than you want as patients. And so I think it's important that we continue to consider novel approaches beyond traditional chemotherapy, but all of those chemotherapy options that I just briefly mentioned are reasonable treatment options. Emerging as a more traditional chemotherapy is a compound called sacituzumab govitecan. Sacituzumab govitecan is an antibody drug conjugate. We don't have any antibody drug conjugates in the hormone receptor positive space. We do, of course, use those regularly in HER2 positive metastatic breast cancers with compounds like trastuzumab deruxtecan or TDM1. Sacituzumab govitecan is now FDA approved in the management of triple negative breast cancer. It is a TROP2 antibody. About 90% of breast cancer will have TROP2 expression. So the recommendation is to not even test for TROP2, it's just to give it. And it links TROP2 to a chemotherapy called SNA38. SNA38 is sort of like irinotecan. It's a little bit more potent than irinotecan, which is its parent compound, so it can't be given independently. But when tied to this humanized anti-TROP2 antibody, it just directly delivers the drug to its binding sites, which is cancer cells. So antibody drug conjugates are interesting in that they are able to deliver the chemotherapy sort of directly to the action, and subsequently often have slightly more favorable toxicity profiles than traditional chemotherapy, which just sort of goes everywhere. The data for sacituzumab govitecan in hormone receptor-positive breast cancer was presented at ASCO, American Society of Clinical Oncology annual meeting in 2019 by Dr. Bardia, and it showed an objective response rate in 31% of the 54 patients who received the drug, and 63% of the patients had at least one response, one area of disease that had responded meaningfully. The median number of lines of therapy that patients had enrolled on this data that was presented was 5. So it was a very heavily pretreated population. We are still waiting on additional follow-up in the phase 3 study, but everyone is optimistic that sacituzumab govitecan will have a meaningful benefit for hormone receptor-positive metastatic breast cancer and give that particular situation its first antibody drug conjugate treatment. There was really no difference in terms of prior treatment with CDK4/6 inhibitors in the sacituzumab govitecan data that we have. Median duration of response was about 7.5 months, which is longer than the numbers I was telling you for traditional chemotherapy, which is again a good sign, especially in a heavily pretreated patient population. I think that globally, as we think about the approach to hormone receptor-positive metastatic breast cancer, what I classically recommend to patients is start with a CDK4/6 inhibitor. At disease progression, likely consider repeat biopsy and genomic profiling in order to be able to select whether or not you would benefit for a clinical trial at that time, or a specific target like PI3 kinase, ESR1 mutation, et cetera, for the management of your disease. Beyond targeted therapy, considering options like fulvestrant, everolimus, other estrogen pathway manipulation where possible, and then moving into the more traditional chemotherapy space as the next line beyond that. I hope that this information is helpful and answers some of your questions, and I look forward to connecting with you all online to going through some details and specific questions you have about what's out there. Okay, thanks.